Good afternoon, everyone. I'm Marty Goldman, and today's just the week of Thanksgiving, so we have a lot to be thankful for. We certainly have a great presentation in front of us that we'll all be very grateful for. I just wanted to mention, I don't have any more details, but the untimely passing of someone that many of us know here in cardiology, Dr. Barry Stimmel, passed away earlier this morning. And I'm sure that funeral arrangements will be announced. But he was a legend here for many years, and he will be sorely missed. He was a pioneer in many areas, particularly with cardiovascular disease and addiction, and was ombudsman here for many years in Mount Sinai Medical Center, so he will be missed. It's difficult to segue into a more pleasant subject, but we are lucky today to have a very important subject. It is unusual how sometimes we luck out and the speaker that we have and the topic that we choose is very timely. Dr. Fuster gives us annually a summary of the important things at the American Heart Association. He also does that for the American College and the European Society of Cardiology. Last week was the first time it was actually presented for CardioSource on the ACC website, and I would hope that you all have a chance to see it. It was really a wonderful summary, so if you didn't have a chance to go to the meetings, or even if you did, it really put things in perspective, reviewing around 20 important abstracts and presentations. One of the most important there was the Improve It trial, which is actually very, very important for today's guidelines in cholesterol and had a big impact. And we're very lucky that today's visiting professor is one of the really leading figures in the country in cardiac prevention of disease, and also very important in interpretation, application of the guidelines. I just wanted to remind people that the next time we'll have this presentation of visiting professor. Again, the format is a brief presentation by our fellow, and then we'll have a panel discussion led by Dr. Fuster. The fellow today put together a really wonderful monograph, and he's going to try to summarize it in 5 minutes. So, Ben Hirsch.
Good afternoon. I will keep it to 5 minutes. So good afternoon, everybody, and welcome to Controversies. We are very fortunate to have with us today Dr. Sperling, who actually has been a mentor of mine since my first month of medical school, so it's very gratifying to have him here today as a leader in preventive cardiology. Today we'll be discussing cholesterol goals and targets, one of the most debated topics over the last year. It is once again in the spotlight after the Improve It trial results were presented at the AHA last week. The Improve It trial demonstrated for the first time that adding a medication to a statin can improve cardiovascular outcomes. Before I delve further into this trial and its implications, I should point out that randomized controlled trials were the type of evidence upon which the 2013 guidelines were based. This in and of itself is controversial and also different from that of previous US and current international guidelines. I just wanted to briefly mention what led the ACC-AHA task force to remove LDL targets and to the recommendation regarding the use of non-statin medications. In their review, they recognized the role of statins in reducing overall cardiovascular risk, but could not find any randomized controlled trial evidence that demonstrated benefits of targeting to a specific lower LDL. They acknowledged that LDL is a strong predictor of outcomes, but expressed caution with placing too much emphasis on the reduction of any measure, including LDL, without a definite effect on reducing overall cardiovascular risk. Except in select populations, the task force did not advise using non-statin agents in combination with statins, particularly in light of recent randomized controlled trials such as with niacin in AIM-HI, as well as with torcetrapib. that these trials demonstrated either no efficacy or in some cases, they actually demonstrated harm. Many, particularly epidemiologists, argue that this recommendation did not place enough value on the biologic and epidemiologic studies that have been done and are being done, including Framingham and the Women's Heart Study. All of these have been used as evidence to support that lower LDL is in fact better. Now we change tone, and as we are presented with new evidence from ezetimibe. Ezetimibe is an inhibitor of the Niemann-Pick C1-like protein. There was a recently published article in the New England Journal of Medicine that showed that patients with inactivating mutations of this protein had both lower levels of LDL as well as lower levels of coronary events. The first study done with ezetimibe, the ENHANCE trial, was completed in 2006. This study enrolled over 600 patients with familial hypercholesterolemia and randomized them to either high-dose simvastatin or combination high-dose simvastatin and ezetimibe. They were followed for 2 years for the primary outcome of carotid intima media thickness. There was no change in between the groups for the primary outcome, despite lower LDLs in the combination arm. However, the use of intima media thickness as a reliable surrogate for atherosclerosis is itself fairly questionable. Now we get to the IMPROVE-IT trial. This trial enrolled a much larger and much higher risk population. So over 18,000 patients over the age of 50 were hospitalized for acute coronary syndrome, had a baseline LDL of 50 to 125. They were randomized to either simvastatin 40 or combination simvastatin 40 ezetimibe 10 milligrams. They were then followed for the primary outcome of time to first occurrence of cardiovascular death, myocardial infarction, unstable angina, coronary revascularization, or stroke. They were followed for 7 years. After 1 year of the study, the mean LDL was lowered to 70 in the simvastatin-only arm and to 53 in the combination arm. And this difference persisted throughout the study. After 7 years, there was a 6.4% relative risk reduction for the primary composite outcome and a 2% absolute risk reduction, but with a very high event rate. So 32.7% of patients in the combination arm experienced a cardiovascular event. And this is compared to 34.7% of patients in the simvastatin-only arm that experienced a cardiovascular event. So with only a 2% reduction in absolute risk, the number needed to treat was 50 over a 7-year period to prevent one event. So despite a 13% relative risk reduction in myocardial infarction and stroke, there was actually no mortality difference between the arms. There are many points about this study that can be observed. Certainly the modest benefit in outcomes. Also, the choice of simvastatin over atorvastatin or rosuvastatin as a drug of choice is a drug of choice post-ACS is another point. And that's currently the standard of care, although it wasn't demonstrated at the time of study enrollment. But however, it is a first randomized trial to show that treating LDL aggressively with a medication in combination with a statin can improve outcomes. However, it also demonstrated another important finding, which is that 40% of patients in both groups stopped taking atorvastatin, highlighting the importance of a meaningful discussion about adherence. Nevertheless, this study provides compelling evidence for the lower LDL is better hypothesis. So moving forward, there's more incentive to put newer medications to the test. Such medications may have the role for the management of patients at high risk for cardiovascular disease if they actually take their medications. Thanks very much.
Thanks very much, Benjamin. Very nice paper you have written on a very controversial subject, and which we will be discussing in some detail today. Now, I'm very pleased to introduce our visiting professor. He's Dr. Lawrence Sperling, who, just to say a few words about him, he was actually born in Long Island, so he's from New York. And then very early, he moved to Emory, were college, medicine, intern, resident, chief resident of medicine, vascular biology, clinical cardiology fellow. This is actually all in Emory, and was in about 1997 that he became assistant professor, and then associate professor, and then professor of medicine. In fact, at the present time, he's professor of medicine and division of cardiology at the Emory University School of Medicine, and then professor of global health at the Hubert Department of Global Health, Rollins School of Public Health at Emory University. So, great mentor and teacher and academic excellence. This is all well manifested in his CV, where he has 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 awards from Emory for academic excellence, awards in teaching, awards in mentorship, and so forth. So this speaks by itself. Then we have a number of international and national societies that he is participating and he has contributed. Appointed to the American College of Cardiology Education Strategy Directions Committee, member of the AHA Clinical Council in Cardiology, ACC Prevention of Cardiovascular Diseases Committee, there again on the ACC. At present, he's the president of the American Society for Preventing Cardiology, treasurer of the American Society of Preventive Cardiology, American Heart Association Epidemiology Prevention Council, and delegate for the World Heart Federation. In any way, he has been really done a lot of work on the first in basic science related to vascular disease, and then he moved slowly into prevention and then global health. Then I will add, in terms of his curriculum, the number of publications that he has, certainly more than 100 and 150 publications, which actually are all around in vascular biology, the issue of metabolism, lipids, prevention, and global health. So he's a very accomplished individual. I think the Emory is very lucky to have him. The Emory has one of the best centers in the world in terms of preventive cardiology, and he certainly has been a pioneer of such enterprise. So I'm very happy to give this plaque to you as to remember our visit today. So here you have, as you know, this is the Anandi Sharma Visiting Professor and the Simon Dag Memorial Lecturer to Dr. Lawrence Sperling for all his contributions. This is for you, and thank you very much for visiting us. Thank you. It's a pleasure. So, then what we are going to do is to ask all the experts to come to the table to work on Juan Jose Vadimon, Harvey Heck, Marianne McLaughlin, Robert Rosenson, Donald Smith, and of course Benjamin Hirsch. And you can sit in the middle, Lawrence. There are enough chairs here?
I think so.
If not, we'll put some.
Awesome. You want to look at these two?
Is this okay? Okay, this is an interesting subject. I see a couple of titles here. One is Cholesterol Guidelines Today and Beyond. And the other title is Controversies in Clinical Cardiology, Improved Residual Risk and the Need for Lipid Targets for Physicians and Patients Alike. Whatever the title is, we are going to be talking about something that is very hot. And I'm going to divide the discussion in 5 different sections, maybe historical. The first is about the controversy between the guidelines that took place in 2001 and the ones that came up in 2013. Then I will present new data that actually I think was published today in JAC about what this change means based on the registry in this country. The patients that today are registered on the 2001 guidelines, what it would mean if they follow the guidelines of 2013. More patients would be enclosed, less patients, and so forth. The third subject will be Improve It, that you have discussed, Benjamin. The next one is subclinical disease and the new trial that actually has been designed here of 10,000 people at young age with the statins. And this is a trial that is taking place in Canada. And then finally, I would like to talk about the PCSK9 future in terms of addressing the issue of lipid metabolism. So I would like to start with subject number 1, which actually the subject is a controversy. I think there is something that is no controversy, and that is that the statins provide 25 to 40% reduction in cardiovascular disease risk. But many patients, actually 60%, continue to have substantial cardiovascular events. So when we talk about the statins, like putting in the water is solving the problem, is solving half of the problem. So this is a more complex disease than just addressing the statins. And this is actually my first question to you, Lawrence, and that is, be sure that not all is cholesterol and statins.
Yeah, so certainly the statins have changed the landscape in cardiovascular prevention dramatically. If we look at the statin era, if we want to call it that, there's been a significant reduction in need for coronary bypass surgery. We know that we can protect our patients with a 25 to 40% event reduction, but your point is well taken that there, despite statins, is significant residual risk. And I think residual risk is quite complex and complicated, and residual risk is way beyond a lipid residual risk. And so although we're looking for the holy grail of the next lipid treatment to reduce residual risk is related to other risk factors that we need to still treat comprehensively and aggressively. Residual risk is related to lifestyle and behavioral factors, and we recognize that low HDL, despite a low LDL cholesterol, is still a potent marker of risk, maybe not so much a target of therapy, and that still is another area of debate and question and controversy that we won't be addressing today.
Okay, Marianne, let's now go into the guidelines of 2001, which is when you were born. And this was actually published in JAMA, and it's interesting. This is the third report of the NCEP, ATP3. And basically, what those guidelines say is that you look first at the cholesterol level and the LDL level, then you add there some aspects of the risk, then you start giving medication, whatever the medication is, and then you try to reach an endpoint which is a level depending from the original risk that you started with. This is basically the story. And when you read, actually I had the chance to read this yesterday, it's fascinating because they say everything we say is all based on clinical trials, absolutely based on clinical trials. And I'm saying this because the new guidelines say the same thing and come completely different. So something went wrong here in the definition of clinical trials. Now, you have been following these guidelines, Marianne. What do you think originally? Let's forget about 2013.
Right. So I think even before I was born, before 2001, the guidelines would subsequently have lower targets, right? We used to say when I was in training, 160 LDL was reasonable, and then it went to 130, and then it went to 100. You know, so there's been a decline, and I would say that to my patients as we had more evidence, epidemiologic evidence in particular, showing that people with very low LDLs had fewer events, and then with some trials like TNT showing that low LDL levels were protective, then we knew that we had to get more to a lifestyle and medication range that had protective effect. And I think that was a very good strategy. And I think the patients actually, when we told them about the numbers, they had a target and it motivated them to meet it, as opposed to just saying, you know, take this pill.
It's interesting what you say, because the history of blood pressure is the same. As guidelines evolve into the GP8 recently, if you go from the beginning, the first guideline was pressure should not be the diastolic higher than 120. And then we should treat it. This is the first one. And then began to drop down, down, down. So both have been really following the same pattern. But it is interesting, following the same pattern, we all were convinced that lower was the LDL cholesterol, better was in terms of cardiovascular events. And I think it's interesting to talk about this in a moment, because this has been the challenge of the new guidelines. Lawrence, what I can read here is when you look at all the previous trials that led to the 2001 guideline, and when you pull all together, you get that interesting line that says, lower is the LDL cholesterol that you achieve with any trial, lower is the number of events. And we really believe, all of us, those lines. And actually, I have slides which are beautiful. You see the line and everything. As you go down, the number of events decrease. But in fact, in none of the trials really did a stratification, like using 2-3 dosages and then saying that the events, except on the, I think you mentioned, Benjamin, I think it was the 4S study, in which there were 2 dosages of simvastatin, and at least you could say something that with 40 milligrams, the number of the LDL cholesterol was a little bit lower than with 20 milligrams, and the number of events was somewhat decreased. So Lawrence, tell me about this, because in fact all those curves really do not come from a stratified approach. It's pulling it all together.
Yeah, I still think it's reasonable to pull it all together, and I know we're not quite addressing the 2013 guidelines yet, but I don't think the 2013 guidelines negate the concept that lower is better. From a pure standpoint, though, if we're looking at the evidence and basing our guidelines, which are a starting point, they're not biblical, we base the guidelines on randomized controlled clinical trial evidence. In reality, these curves or lines showing lower is better based upon the biologic data, the epidemiologic data, and the randomized controlled clinical data still, I think, are reasonable ways to conceptualize our approach to lipid lowering. But I think there's a difference between guidelines and performance measures, and I think we have to be very careful about not confusing those or getting those intertwined. We were getting ready by CMS to get graded or measured on our numerical LDL targets and goals, and if you had a goal of under 100 and your patient was 102, we were going to get a ding. But if it was 99.9, we would get a gold star. And so these numerical targets and goals are on a continuum of risk. And I still think this continuum of risk holds true based upon the totality of the evidence, which we shouldn't be blind to.
Dismiss. You should not dismiss. Robert, what is interesting, just to become more convinced about these levels lower is better, you have secondary prevention and primary prevention trials, and there are 2 different lines, which is fascinating. The secondary prevention, lower is the LDL, more impact you have. And in the primary prevention, still you have the same line going down, but less striking, but it still goes down. So you are convinced that those lines, despite that there was no single trial, only one, that look at is something believable.
So there's 3 parallel lines. I wrote a review that did a meta-analysis of patients presenting with ACS, stable coronary disease, and prime prevention. And those, of course, at the highest risk have the highest event rate, but the relationship between LDL cholesterol lowering and events is still, it's actually log linear. And in between is secondary prevention, lowest is primary prevention. But this whole argument about LDL cholesterol was really challenged in some ways by Rod Hayward at the University of Michigan, who wrote a very insightful, provocative article in the Annals of Internal Medicine that said is that the LDL cholesterol is at the effects of the statins which have many, vascular protective effects. And that's why he changed the argument, and that discussion, very scientifically sound, was brought into play, and I think has had a major underlying influence on, these current set of guidelines.
Well, I think there were 2 arguments, and then we will move very soon into the 2013. One argument is statins do many things. Yes. So therefore, all this obsession about LDL levels may not be pertinent, but this is like denying that, I don't know, that today is the 24th of November. It's like, that's one issue. And then the other issue is the fact that as we said, there were no trials that really directly work on the different levels on a single trial to say that the results were different in terms of events. But I guess the 2013 guidelines come in, but let's say what is different into the 2013 guidelines. In fact, there are three things that are different. There you do not start with an LDL level, is one of the 4 items. You start with the concept of a high-risk patient. That's really how you start. And you identify this high-risk individual, an individual who has atherosclerotic disease, an individual who has an LDL more than 190, which is a lot, and then whether you have diabetes or you don't have diabetes, then you use that famous computer approach, which is more than 7.5 risk or less than 7.5, which has been very debated, and we will talk in a moment. And then at the very end, higher is the risk, higher is the dose of use of a statin, and then there is a moderate use of a statin. But the fact of the matter, you are not based your decision on LDL alone, you base your decision on a high-risk patient as a total. And then you give statins, and you only use any other drug if the statins for some reason do not do the job, and finally you forget about the levels. Now, I'd like to perhaps for a moment to pause and says, what are the pros and the cons of the 2 different strategies? The one in 2001 and the one that I just mentioned. Well, in favor of the 2001 is all the organizations in the world sticking to that. There is no single organization, and I have here 16, which I'm not going to bother you, in which the concept of just forgetting the levels, they are in disagreement. Europeans, South Americans, and Canadians, and all of that. So this is actually a good argument in favor of 2001. There's a second argument that I would like to perhaps pause and pay attention, and I'm going to ask Dr. Smith about what he thinks. And this is the concept of adherence. Let me first of all present you the data. The data on adherence is, we presented this recently, we have studied adherence in 2,000 people from 5 countries. And the adherence in this case was to medications, among them were statins, in patients following myocardial infarction. And what it was found, and this was published in JACC actually yesterday, what we found that only 45% of the patients following myocardial infarction at 1 year, they are taking statins, aspirin, and an ACE inhibitor. And the question is, these people feel well, but there are other reasons for it. And the reasons we found were the following. I think this is important. First, if you are young, younger you are, higher is the likelihood that you will quit the medications. Interesting. The second is that more medications you take, less you decide to take. The third is the issue of depression, which is in 20% of people following myocardial infarction. The other is the support of your environment, family, friends, and so forth. And fifth has to do with the insurance. But here comes the bottom line. Those who follow the medications, which were 45%, they look what was the level of blood pressure, what was the level of cholesterol. Like there is a motivation or an incentive if you have a level. And this is why I want to ask you that to me this is a critical issue in favor of 2001. You have a goal to achieve, which is very much an incentive. And I'd like to ask this question to you, if you agree with that based on your experience in the lipid clinic.
Well, I think that the whole point of this is people want to feel in a very safe zone. And so if you don't define a safe zone, then you don't know if you can relax and continue on or what you should do. And I think that confuses people. So that's one reason. And the second reason, I don't think the new guidelines stop looking at LDL levels. That they do not do. They say that there's no evidence that these are the goals that you should strive for and then stop and say that's okay. And I think that's very important because many people with MIs, they come in with less than 100. And therefore to get them to 70, I don't know quite what you're doing. And if you get them down to 50, you'll have a bigger effect. So for me, this has been extraordinarily helpful in starting with high-dose statins on people who are already at sort of lower levels, but I consider it major risk. So I think they've been very helpful in doing that. But what you're saying is true, that what I use is the Nissen argument. Basically, if you look in the coronaries, that if you're less than 80 for LDL, you're going to stop forming plaques, and if you're down in the 60s, in fact, they're going to start shrinking up. And so that's, you have to get something as a picture to the patient to sort of begin holding on to in terms of where they are, and if you want to push them or whatever you want to do. But I think, to me, the most helpful thing is I was giving too few low-dose statins in people whose LDL started low. And this helped me push them up and get them down lower, where we now know in the 50s is good. So it's helpful to have them, to get people focused on where they want to go. Yes, it's very important.
But and at the same time, what you are saying is that it's important to start in a high-risk population. So you basically, following your argument, you are in agreement with both approaches, and probably you use both of them.
Yeah.
Well, I think this is where the future is. But let me now present, Dr. Heck, the data that was published, I think it was today, in JACC, which is interesting. And this data actually is based on a registry, which is the registry of the American College of Cardiology in all the NCDR, which is all the outpatient clinics in the country, as you know. And in this registry, they follow patients between 2008 and 2012. And these patients were supposed to follow the guidelines in terms of lipid lowering. They were the guidelines of 2001. And what they did, and we are talking about over 1 million patients, and what they did is they looked at these people and said, how many follow the guidelines of 2001? This is all registry. And how many people would be missing the guidelines of 2013 or the opposite? So this really is the question. And the results are very striking, and I have a question for you, Dr. Heck, and another for you, Lawrence. They found that today in the United States cardiovascular practices, 32% of patients that were eligible for 2013 guidelines are not taking statins if they were based on the 2001. If this strikes you, it means that these guidelines are much more strict, because people are saying, these guidelines are not so good, but maybe they are. Yeah, I'd like to ask you.
I think that both guidelines are really fatally flawed, so to me it really doesn't matter which one has the greater adherence. The basic problem is that the concept of atherosclerosis itself being a more powerful indicator of risk than risk factors for atherosclerosis seems not to have caught on in this country. And we have an enormous amount of data now from coronary calcium that whatever risk factor-based guideline you're talking about, it's wrong in the...
Yeah, but we'll talk about this in a moment. I have a question for you, though.
Yeah.
And the question is, it strikes you that this group that follow the 2001 guidelines are missing 32% of the patients that would come into the guidelines of 2013. This is really my question.
Well, it doesn't mean that the 2013 guidelines have correctly identified those at risk. Perhaps the ones that are not taking it with the 2013 guidelines didn't need it to begin with.
Well, this is the question for you, Lawrence. The question is, this is the data. We are treating more patients today with the present guidelines than it was in 2001, but this means that the outcomes will be different. This is the critical question here, which Dr. Heck actually is pointing out.
Yeah, I think the Jack paper that you're referring to, if I'm not correct, is that Tom Maddox's paper. And there, from the Pinnacle Registry, in these million patients, a large percentage of them already had known ASCVD. And so it was not a primary prevention group where Dr. Heck was talking about potentially using coronary artery calcium scoring to further risk stratify a population at risk for events and needing more intense therapy. What I think is interesting, though, is as we think about improving it, because we're going to talk about the Improve It trial some today, is really where we can improve it is matching high-intensity paradigms for treatment with the patients at high risk. And I think the JACC data points out that we're still not doing that in clinical practice through registries. I think where we can also improve it, as Dr. Fuster has pointed out, is in the patient-clinician discussion about the indications for statins, their benefits, also their risks, but also that statin therapy in the high-risk patient is a lifelong approach. And having the patients understand why that is the case and why that is the need, hopefully could potentially improve adherence, although it sounds like there are other factors that point to potential medication adherence rates or lack thereof. If we look at the new guidelines, though, compared to the old guidelines for primary prevention, there are questions and concerns that more people would be treated under the new guidelines. And I think that's where Dr. Heck was alluding, that how do we know we're even treating the right people? We're treating a population that is at risk with this risk calculator or estimator. And there have been some questions about extrapolating that to across the board the populations.
Well, these are two comments. One is they look at the risk calculator in this NCDR and it works. They say that the margin of error is ridiculously low. So this is not an issue. There is so much controversy about that, but it doesn't make a lot of difference. So I think this is one of the issues that they make very clear. But let me now present to you my view that I think the future is going to be a combination of both, and we already talked about the goals, increase adherence and so forth, but taking into account that today in this country, and this is in the NCDR study too, 30 to 40% of people that should take statins, even with the 2001 guideline, are not taking it. The fact that now with the 2013 more people will take it, in my view, compensates with a problem that was already with the 2001 guideline. I say this because this is an argument that without having endpoint data, at least you have more people that are going to be treated when half of the people are not being treated even with the 2001 guideline. And this actually leads to a very interesting aspect Benjamin has been talking about, and I want to actually present this to you, first of all, conceptually, Juan. And to me, the new guidelines saying you use statins and you use only a non-statin when things are really rocking, to me is really almost a joke. because in the population that we treat with the statins, the number of people who have side effects is incredibly high. And I'm not talking about muscle pains. I'm talking about sleep, sexual dysfunction, dizziness, fatigue, and so forth. All of us who have seen patients with the statins, we know this, but this is in no trial. The trials don't look at these side effects. So we are stuck in a large number of patients in which we cannot even use statins for the reasons I'm saying. And now I want to ask you, Juan, before we discuss Improve It, what was your feeling about the 2006 approach to ezetimibe with intimal medial thickening? Do you think that is atherosclerotic disease, or this is something that is even not a...
It could be. The problem is when you see a thick carotid artery, you don't differentiate between atherosclerosis and about hyperplasia. But remember, in the 2006, almost everybody believed that this was one of the best markers for atherosclerosis. We didn't have the same evidence that we have with calcium score or with MRI. So there is a little bit of a problem. But let me tell you, before you switch...
Except that you and I think Farku have an editorial about it in Nature Reviews saying we do not believe on the endpoint. In fact, it was a big fight, the number of correspondence that came afterwards. You see, intimal medial thickening is a physiological phenomenon. And actually is completely physiological. If you have hypertension, you thicken more. If you have less hypertension, you thicken less. But thickening happens with age. And to use that as an endpoint of focal atherosclerotic disease was disturbing. And it also happened with the diabetic drugs. Let me finish with him and then I go to you.
But I think before we move away from the guidelines, I think that one of the new guidelines tried to be proactive. He tried to prevent because it's very statin-centric. And if you read the guidelines, nobody says, I mean, they only say that the problem may be muscle problem. They don't talk about all the other complications that probably are the reason why people stop taking statins. Yeah. So, and if you believe in the pleiotropic effects, and you believe in the safety and the effectiveness of statins, they are good. The problem is that not everybody responds the same to the same doses of statins.
True.
And the assumption that by giving a high doses of statins you will reduce 50% of your LDL, I think that this is not true at all.
Robert?
I just want to make a comment about the ENHANCE trial. When I was in Chicago, I was one of the lead investigators in the FH consortium that was put together by John Castelline. And we had individuals who had LDL cholesterols over 100 milligram per deciliter. We tested every new drug to try and get them lower, under 100, less than 70. So these were individuals who have been treated for decades in some of the world's best hands. There wasn't much intimal medial thickness to start with in the ENHANCE trial, and it's very difficult to demonstrate a change from the lack of change. So we need to understand the populations that were studied, and I think that the ACC/AHA guidelines, that are not interpreting trials within the context, I think are disingenuous to begin with. And as an example, statin-naive patients in the METEOR trial, the rosuvastatin trial, had IMT that was over twice as thick, and it did show benefit. So again, we need to understand what we're looking at before we start making these blanket conclusions as certain people have around the world.
The point I was making is even intimal medial thickening is not even a surrogate endpoint. It's even less. That's what
I don't disagree with you, but then you go on to the ezetimibe trial and look at calcific aortic stenosis, and what animal model has ever shown you can get calcium out of the aortic valve? None. So, I think there's conceptually very poor study designs that set this field back, probably 10 years.
Well, this is a problem with industry that obviously they need results soon, and the endpoints can be very soft. Let's go into the Improve It trial. I think if you recall the history of ezetimibe, the whole history is they didn't have good trials, and they marketed the drug like crazy without having good data. And then came this study we just discussed, in which he failed, and it appeared it was dead. What is interesting is the courage of investigators to continue to the trial that they started at that time, which is the Improve It trial. And there were actually 3 questions. First is, Thus, lowering LDL cholesterol with a non-statin agent, ezetimibe, reduced cardiac events. Pure LDL cholesterol drug, a drug that prevents absorption of LDL in the GI, is lowered better. And actually, it's interesting, the type of LDL cholesterol that they were testing was almost what we consider today normal, because these patients, most of them had been treated with the statins, and it is safe. Well, as you know, and as was mentioned by Benjamin, this is a type of a study with a high-risk population. These were people who were admitted in a setting of an acute setting with a STEMI or non-STEMI MI or a stable angina, and then they were started and they were randomized. In addition to that, they had a significant risk factor, these people. They have diabetes or previous peripheral arterial disease, CABG, multivessel coronary disease, cerebrovascular disease, and so forth. And the patients, as you know, were close to 20,000, was actually randomized, this high-risk population, in ezetimibe and simvastatin together, 10 and 40 milligrams, respectively, versus simvastatin 40 milligrams. The average follow-up was actually 7 years. And the primary endpoint is the usual cardiovascular death, myocardial infarction, and stroke, in addition to coronary revascularization and hospitalization for an stable angina. The results actually were striking in terms of the LDL cholesterol lowering, was from 69.5 versus 53.7 when they use both drugs together. And then in terms of the endpoint that I mentioned, it was a decrease, was not very significant, but were 20,000 patients, 34.7 events in the Simba group versus 32.7 in the combination of both. And when they really went specifically into the endpoint of a stroke, myocardial infarction, and death, the drop was from 22% of these three types of events to 20%. And when they went directly into each particular event, there was also a trend, not necessarily significant in all of them, in favor of the combination. So here we have the answer to the three questions of the investigators, and that is, non-statin lowering LDL with ezetimibe reduces cardiovascular event. The answer is yes. Event lower is even better. Even lower is even better, which is also true. And then this confirms that ezetimibe has a safety profile which I have not been discussed. So Benjamin, you spent actually most of your discussion today based on this trial. What turned you on this?
So this is the first trial to show that adding a medication to a statin, adding a non-statin medication to a statin, can actually improve outcomes. So this now complements the whole body of evidence that exists, including epidemiological studies, genetic studies, biologic studies where patients with a beta lipoproteinemia who have lifelong levels of 30 to 70 LDL actually don't have any evidence of atherosclerotic disease. So I think it complements all of that. That being said, there was a very modest benefit. The benefit was a 2% absolute risk reduction over a period of 7 years. So if you were to look at the number to treat over 1 year, that would be 350 to prevent an event. So the other thing is that extending these findings to a lower risk population would be certainly premature at this point, and I think people would probably be inclined to rush to do that. So those are our main points.
Lawrence, this is Benjamin made very good points, and now let me start asking you: have you used ezetimibe in the last 3-5 years?
Certainly. I still have used ezetimibe. We see in our prevention center at Emory many high-risk individuals who frequently can not tolerate the high-intensity statins. We see people with familial hypercholesterolemia who often need to be treated with aggressive combination therapy, frequently 3, 4, 5 drugs, and we have an LDL apheresis center that's been in operation now for 12 years. So we have used ezetimibe. The SHARP trial looks specifically at individuals with renal disease, and if you were not a dialysis patient but had renal dysfunction, there was evidence there that the addition of ezetimibe to a statin further reduced risk. And so, but people were anxiously awaiting the Improve It trial, and there was a lot of interest in that at least the DSMB hadn't stopped this study early for futility as they had with a study like AIM High. And then
Well,
the data was presented at AHA.
I have a follow-up question for you and for Benjamin, and that is, let's assume that these patients had not been on statins, because here's where I think the investigators were very courageous. These patients, most of them were already on statins, and they begin a trial adding a drug when the LDL is close to already normal. So the chances of seeing LDL as a winner with ezetimibe were extremely small. So now I present to you the situation of a patient who comes with an LDL of 170, doesn't tolerate the statins at all. You don't think that ezetimibe would have a good result, even better than what we see in this trial? I mean, what would you predict?
Well, prediction would be 15 to 20% reduction in LDL, although there's a bell curve distribution around that. Some people might have a more vigorous reduction in LDL. It would be hard to extrapolate the findings of Improve It to that population, the statin intolerant population. But biologically, we would hope that reducing LDL in that population would have a clinical benefit. But I think it would be hard to utilize that scientifically. I think clinically, though, the new guidelines tell us that we should use the guidelines as a starting point, that these guidelines are not dictum, and that we should also, along with guidelines, take into account clinical judgment and patient preference. And so that would be an account where clearly I'd be using my clinical judgment at this point and recognizing that that patient with an LDL of 170 who can't tolerate a statin, especially at their high risk, warrants LDL reducing therapies.
Marianne, you don't think that if you use ezetimibe today, you are not going to look at LDL that you achieve?
No, I would still be watching the LDL. I think from...
You will not watch, just, I want to be sure I hear you.
I would be watching the LDL.
Okay,
still.
because that's one of the issues that is going to start making the change here, because 40% of people do not tolerate the statins well. So you will watch LDL.
I will watch it. I think this study gives credence to the fact that as we know, as active cardiologists, we use other things all the time. I think for a general population of internal medicine specialists who might not be, more likely to use ezetimibe now, they might feel more able to use it to do what we've known, that to getting, cholesterol lower is better. But I think what's interesting is I would love to see what happened to the 42% of people who, did not take the drug, and why. And I think that, even though they say that there was a low risk of liver cancer, muscle problems, and gallbladder disease, they stopped the drug for some reason, right?
Okay, I'd like to ask a question to each of you now. And there are 3 answers, and you have to give one answer, not 3 answers. Question number 1 is, are you going to continue to follow the 2001 guidelines? Question number 2, are you going to really strictly follow the 2013 guidelines? And number 3, are you going to use somewhat a combination of both? This is the 3 questions. Okay, Don.
I think it's all yeses. I mean, I think it would be all yes. I'll follow the new.
No, you have to say one.
Oh,
You should. So yours is number 3.
Yeah, it's 3, yes. Right.
Okay. Robert?
3, and that's what I put in up-to-date medicine. It's a hybrid.
3.
Yeah.
3.
Benjamin?
I must insist on option number 4, which is neither one.
Number 1.
Neither one. No,
Neither one?
neither one. Neither
Well, I
the
will
two.
get back to you in a moment.
Okay.
Juan?
Number 3.
I want to be different, but I would say for primary prevention, I would use the current guidelines more.
Excuse me, Marianne?
I think for primary prevention, I'm using the current guidelines more. Using the, using the atherosclerotic cardiovascular disease risk calculator, I've been able to, I think, show my patients that the benefit of not just the LDL level, but what the blood pressure is. And so if you lower the blood pressure in that calculator, you can reduce their risk. And so I think it's been very helpful, especially for patients' behavior modification by showing.
Okay, but the overall thing is about that most of you is number 3. Now, Dr. Heck, don't tell me you're going to bring calcification of the coronary arteries here.
Of course I will, you know me.
Why?
Because there's so much
This is
data.
not the discussion.
There's so much data that risk factors really don't do well in establishing risk. If you look at the net reclassification index in the intermediate risk category, in 3 prospective trials, the NRI is anywhere from 50 to 62% in the intermediate risk category, and the high risk category, it's a third of the patients. So if you are a doctor and you have a patient in your office and you say you're intermediate risk and this is your risk of a heart attack, you could do just as well by guessing, because you're going to be wrong at least half, if not 2/3 of the time, on the basis of subclinical atherosclerosis, which is far more potent than the risk factors.
Excuse me, what are you going to do with your patient? Are you going to do a calcification on everybody who walks in the street? I just need to know, how do you manage?
Well, I think the 2010 risk guidelines in the asymptomatic patient were really pretty good. They have a class 2A recommendation for the intermediate risk patient. Coronary calcium is reasonable in the intermediate risk patient. And not only for intermediate risk patient, but all diabetics, and the appropriateness criteria is that it's reasonable in young, otherwise low-risk patients who have a family history for premature coronary disease. So I would use it across the board in all intermediate risk patients. High-risk patients takes a lot of courage to downgrade them, but I think if it's wrong 1/3 of the time, I would use it in high-risk patients as well, and in selected low-risk patients, like those with a family history of premature disease.
We're going to discuss this subject, this is the next subject, but I have to say that I think the subclinical disease, which is what you are talking about, probably has a significant impact on early events, but if you follow patients for 25 years, I don't think will be different than Framingham. It depends what your goal is. And when I don't have the data, I can only say to you that, well, we have already 7 years of follow-up in 10,000 patients with calcification in Madrid and here. And the papers are actually now being reviewed. And I can say to you that calcification is important to predict early events, which is subclinical disease, but I'm not sure it's going to be superior to Framingham when you look at that 15, 30 years. What do you think, Lawrence?
I think it probably will be, because I think you're making decisions based upon the coronary calcium earlier than 20 or 30 years that would significantly affect management and the outcome. I think you mentioned adherence as well. When you actually take the coronary calcium scan and show it to the patient and say, here is your plaque, there are at least 3 large studies which show a significant, really major dramatic improvement in adherence.
It's not our study. Let me tell you why. And I discussed this with Dr. Friedman not too long ago. The patient who comes to you is ready to do anything you tell. The patient who is in the street does not. Our data already showing to the patient that there is subclinical disease is for a month is troublesome. After a month, this is a problem of the scientist, which is quite different than the patient who comes to see me because wants to know what is going on. That's a completely different story. The 3 studies you mentioned are studies done in an office of patients who are very reliable. This works. It's not an issue. But most of the world is unreliable. And I just want to know, Lawrence, what you think about this. Is a critical discussion, actually.
Yeah, so we know that having a 0 calcium score has a high negative predictive value for a period of time. We used to say 3 to 5 years. There was some data presented by the Hopkins group at AHA that said it's actually quite good for 10 years, and there was some data presented by the Emory group that said it's quite good for 15 years. But really, coronary calcium tells us where our patients are in the timeline of atherosclerosis. And we know from MESA data that many people with calcium scores of 0 at time 0, at a later point in time, will still develop coronary artery calcification. So if we're looking at lifetime risk, and realized that clinical trials, we're looking at a little snippet of treating these patients at risk for 3 years, 5 years, I guess with Improve It 6 years. But if we're treating our patients for life, which is really what prevention is about, high-risk patients are still high-risk patients, and we can risk stratify them with measures of subclinical atherosclerosis, but these patients over their lifetime go on to have atherosclerosis.
Yeah, it's going to be very difficult to follow these patients. Actually, I will present to you the trial that we designed with Dr. Domansky, actually, and Michael Farku, in 10,000 patients for, you want to say something, I think, Dr. Heck?
Yeah, I just wanted to introduce an even more controversial area, which is the question of repeating the calcium scan. For instance, in patients who have 0 calcium scans, we're not saying that's a lifetime guarantee, but it's very reasonable to repeat those in a period of 4 to 5 years, at which point most of them, at least 85%, will still be 0 calcium scores.
Yeah, well, I think all of these techniques, and we are all in favor of those, and 3D ultrasound is fantastic when the patients are reliable, but I'm not entirely sure, as you land in the world, all these technologies are going to have an impact. Remember now what Framingham is suggesting, and the World Heart Federation, that even don't measure cholesterol. You just measure blood pressure, you measure obesity, and the type of how the guy eats, and there is no much difference whether you add cholesterol or you don't add cholesterol. So simplicity is the way that the whole game is going, and we cannot make these things more complex. And talking about simplicity, let me tell you the so-called ECAT trial, which just started in Canada. This is a trial that we have been designing for a couple of years, and it's basically, this is in patients of 35 to 50 years of age, no prior history of coronary artery disease, and the LDL cholesterol level is more than 70, but they have a significant risk factor that may be, or diabetes and so forth. And these patients are 10,000, are randomized over a period of 10 years of follow-up into simvastatin 20 and placebo. And these are patients that come to the practice. And the question is, can we follow these people without any great complexity, which is the key of the trial, and see what happens? In fact, many of the people suggested us to put calcification and all of that, and we actually rejected because it would make things extremely complex. And the patient doesn't want complexity. I'm just only presenting to you this because it's a study that started last month and is going to last for 10 years. And the patients are being entered at this moment, actually in Canada. Any comments, Lauren?
Interesting trial design. It is real world in this population at some increased risk, a 10-year horizon. My thought would be that in these individuals in Western society, so it's in Canada, is that correct?
Yeah.
That those who are adherent to therapy over that decade will demonstrate a reduction in cardiovascular events.
So I think it's a trial that's doomed to failure because in that age group, probably 60 or 70%, if not more, would have 0 evidence for subclinical atherosclerosis.
I correct you 100%. Let me tell you, we just finished a study in 4,000 people in Madrid, where they were between age 40 and age 55. And actually, we found, I presented this the other day, in males at age 50, they already have 2/3, 2, 3, 4, or 5 of the segments of carotids, iliofemoral, already with focal disease. So what I'm saying to you is that that's why we want to start at an earlier stage. Is the reason for the data that we are obtaining.
I have a hard time with that concept because I know the data that you've shown in the HRP study as well, that at least 60% of people with 0 calcium scores have identifiable carotid plaque. I think the presence of carotid plaque is, by yay or nay, is not going to be enough. You're going to have to raise and determine a threshold of carotid plaque that equates to a risk.
I hope you are not a reviewer of the paper,
I'm not.
It's coming out because we have 300 events, which in fact is tabulated with event rate. So, yeah.
I have a question for the study. Let's move away from the calcium. What will happen in the placebo group if somebody has high cholesterol, are you going to ban the use of statins or not?
No.
Because this may be unethical.
No. They are going to be entered into the study. It's an intention to treat, and you will have to treat it.
Mm-hmm.
It's an intention to treat it. It's a study really in the street, and this is what we want. I think I want to finish by the, and maybe you, Robert, you're very well, you can give us a summary. This exciting area of the PCSK9, as you know, PCSK9 blocks the entry of cholesterol into the liver, or LDL. If you can block PCSK9, means more cholesterol will enter, it will be less in the blood. And the results are quite striking thus far by the 3 different drugs that are neutralizing the LDL levels, they drop into half or more than a half. And then the question about the Odyssey long-term study, in which there are a number of events that already is a post-hoc analysis already showing that the number of events significantly decrease with this kind of subcutaneous injection once every other week of the neutralizer of this. Can you give us a sense, because this is quite exciting, and actually the side effects are quite negligible.
Yeah. I just want to make a point about, improve it. This started at an LDL cholesterol level under 70. The previous studies that failed, I thought, started too low. And the relationship between LDL cholesterol events is log linear. It's not a linear relationship. Diminishing benefit, and that was part of the comments. PCSK9 inhibitors really afford the opportunity to test the lower end. You can drive the LDL cholesterol down to unmeasurable numbers, and even with the direct beta quantification, you can get down into the single digits. And these trials are designed appropriately, in my opinion, because they're looking at individuals with LDL cholesterol levels greater than or equal to 70 milligram per deciliter, which had been the previous threshold before Improve It, and then driving it down probably to the 25 to 40 milligram per deciliter range. In the Odyssey study, they allow for dose escalation, so you'll get more of a dose ranging finding in that trial, and that I think will fill in all the gaps that we need with regards to LDL cholesterol as a surrogate marker of disease, which it had been longly held to be before some of the criticism from Nissen and Krumholtz about the failure of the Zetamib study.
Okay, thank you. When do you think we will have definitive results by which the FDA can begin to look at?
Both lead companies have already gone to the FDA, and the PDUFA date, whatever, is September 2015. Whether they get approved for conditions other than heterozygous FH and statin intolerance remains to be determined. The trials are more than 50% enrolled. As you mentioned, for the Odyssey alternative, the post-hoc analysis, there was a 54% reduction in events at about 1 year. And I think that the signal is overwhelmingly positive, but the limitation of a retrospective look in small studies of different patient populations. So, we'll see if the FDA will go back to the LDL cholesterol lowering as a target, but the major gatekeeper is going to be the insurance companies, because they give thumbs up, thumbs down, and I've been very pivotal with CVS Caremark trying to give good guidance as to when these agents should be used earlier and when they might be delayed.
Lawrence, final question before we open this for the audience. You saw the data from the West Scotland, very exciting. It's 20 years after the publication, the curves continue to diverge tremendously with the use of statins. I mean, this is not exciting.
Yeah, it certainly points out that prevention, and that's a secondary prevention study, is lifelong, and that statins should be an important part of our armamentarium of lifelong therapy. But it is very powerful and very important to recognize that first and foremost, getting our patients at high risk on a statin, let alone a high-intensity statin, should be our first order of business.
Thank you. Questions or comments? Dr. Friedman?
Yeah, 2 points. One is, on my desktop, I have an icon, and it's a calculator from the MESA trial, and it combines the Framingham study with the calcium score. And it's staggering how often and how profound the change in risk is when you plug in that little gizmo. And I've been using the calcium score for like 15 years on almost all my patients, really over the age of 60, and found it very revealing, a lot of surprises. And the second point I wanted to make was, if you talk to a bunch of old-fashioned docs who followed the target to treat, I think they'll tell you in complicated patients even, there's like a 90% reduction in risk, that you basically wiped off stroke and heart attack off the face of the map in your patient population. And so when you hear people talk about 40% reduction in risk, you wonder, why should I listen to any of these things? Because I think for thousands of doctors across the country, they have a strategy that's incredibly effective.
Lawrence, do you want to comment on this question?
Yeah, so first, as far as the MESA calculator, I do think that coronary artery calcium scoring, out of all of the additional measures and markers we have out there, is the one that moves the ROC curve more significantly in terms of reclassifying risk. So I think that's an important thing to recognize, but we also need to think about who's the right patient in which to measure coronary artery calcium scoring. I'm not sure we could necessarily score the whole population. As far as risk reduction, we know from statins alone about a 20 to 40% risk reduction from the totality of the evidence related to docs that are out there in practice. If you begin to add up all of the strategies for risk reduction in patients for secondary prevention, and you add up a statin and an aspirin, lifestyle behavioral changes, there you can approach right now maybe an 80% risk reduction if you add in ACE inhibitors, beta blockers. That's for secondary prevention. For primary prevention, I think primary prevention is a more difficult population to classify and categorize, because there's a lot of differential in the risk in primary prevention. But I still would, I would say to your friends out there, be striving for that 90% risk reduction, because the totality of their treatment in a comprehensive fashion is probably what's most important. And there's some data from Berry2D that I've been involved with that shows Berry2D, you can bypass them, you can stent them, insulin providing versus insulin sensitizing regimens. None of that seems to impact outcome, but what impacts outcome the most is a comprehensive approach to all of their risk factors, and I do think that makes a difference.
Other questions?
I have a hypothetical question for everybody in the table and also for you. We are talking about the improvement, but if we apply the 2013 guidelines, those guys are high risk. Therefore, they have to be treated with a high potency statin. Do you think that the combination of Simba and ezetimibe will be positive versus atorvastatin 80?
Lawrence,
And the caveat with the do guidelines, simvastatin 80 is not recommended by the FDA.
Okay,
So-
rosuvastatin.
Okay, so no,
Yeah,
just
lower
saying that
dose.
was also interesting.
I think it's a very good question. So what do you
Following
think?
Dr. Fuster, yes or no?
No, I would.
Don't say calcium.
So the question is,
no, but-
Atorva 80 or Rezuva 40 versus Simba 40?
Low dose of both.
Yeah.
10 of
Like
ezetimibe.
No, I think the future is low dose of medications, and I don't think the lipid field is different than the hypertensive field, and that is lower dose, less side effects, more effectiveness. So I believe that we will end up using a lot of low dose statin with ezetimibe. This is my prediction.
I don't think so. I think the number of pills that goes up, the number of adherence, I think, goes down. And so
No, but it's a polypill, the Vitorin.
Yeah. We need to step back and ask, why are we using high-intensity statins? Because in the first 6 weeks to 3 months, high-intensity statins are better than low-intensity statins. High-potency statins are better than weaker statins. You showed with Zai and Michael that there's reduced inflammation over a short period of time, Atorva 80 versus Atorva 10. That's why we do it. We're missing the big picture here. And the other thing about ezetimibe is that in monotherapy, it activates HMG-CoA reductase. It activates, Rho kinase. There's more inflammation in monotherapy. So you really need to use ezetimibe in the context of high-intensity statin, and then add, additional LDL cholesterol lowering with the second agents. We have to go back to the human, studies of atherosclerosis. And I completely endorse high-intensity statins, and we have that paper coming out in JACC in February 2015 that says that people are getting completely confused by the LDL cholesterol target and not following the evidence. And, it influences the utilization of other therapies as well. So, I think that the doctor that's trained on the evidence is the one that's going to do the best for the patient.
I want to understand, so how do you treat your patient?
If somebody comes in with ACS,
No, just chronic stable coronary disease. But because the 80 milligrams is in an acute phase, but most of the patients, that's what my question is.
TNT trial, John LaRosa, Atorva 80 is better than Atorva 10. So I'm putting on Atorva 80 when they have symptoms, and I start backing down. So, as a reviewer for NIH on the guidelines, I fought this, it was in my comments, more side effects. But I think that seeing how doctors practice, and we have 100,000 people with MIs or hospitalization for acute coronary events and Medicare database, I think we have to follow the evidence, and then if people have side effects, you go down to what they can tolerate. I think that's scientifically sound, and I think it's the right approach based on the biology.
Except there is an approach, Lawrence, and if you are in agreement, there is an approach to do completely the opposite. It's starting with a lower dose and see what the level is and go towards the higher dose. I'm just saying this because most of the clinicians use the second approach rather than the first, starting from the top, go to the bottom. I'd like to comment.
It's certainly under the prior guidelines in clinical practice, most physicians were starting at the lowest doses, and even though there was not evidence to do so, titrating up incrementally till they got to their either most tolerable dose of statin or a certain LDL target or goal. I think if we think about this biologically, there's a very different risk and approach to those who have had an acute coronary syndrome versus those with stable coronary disease, and we'd have to have good studies to really determine this. But once you've treated that high-risk patient, a portion of them, after 30 days, a month, 6 months, and a year, they slip off the curve of the high-risk ACS patient, and they now drop off into the curve of the patient with stable coronary disease. I was talking with Ben about this a little bit today in terms of how do we, within a population, try to figure out who doesn't really have stable coronary disease anymore, but still is activated or inflamed, where maybe we'd need more aggressive therapies. Now, that's scientifically a much more complicated way to approach it. From a population standpoint, though, even with stable coronary disease, the higher dose or higher intensity statin versus lower intensity is going to reduce risks. But within that population, there are probably several subpopulations of individuals.
How long does it take for cardiologists to titrate to target? 2 years in the National Registry for MI. It's too long. That's why, top-down approach, scientifically based, evidence-based. You got multiple comparison studies, and
Yeah, I would favor that as well. I used to say go for the goal. Don't start a low dose and titrate. Start with a high-intensity statin, and if that was not tolerated, back down from that or figure out alternative approaches to care.
it's a paradigm shift, and that's why there's resistance, right? It's a new way of thinking, but there is a scientific background, the new science.
Yes, Benjamin and Marianne, you have comments?
So I would say a lot of this has to do with adherence. While I agree with Dr. Rosenson regarding the extreme benefit of starting high-dose atorvastatin, I think that if a patient has adverse side effects from a high-dose medication, they'll probably be reluctant to try another statin. So if you titrate up, and this is also has to do with involving the patient in the management. So if you develop a scheme that allows the patient to feel that this is the right way to go, we're going to try to just titrate up, and they're willing to do that, that might be a better way to go. This is for stable ACS. When it comes to acute coronary syndrome, and I would go directly to atorvastatin 80 or rosuvastatin 40, and in fact I know Dr. Rosenson is doing a lot of work on how that's not even taking place, and there's certainly benefits to to having both of those on board, particularly within the first month following an acute event.
Marianne, you had a
Actually,
comment?
I have a question for the experts on the panel about cognitive effects. And that instead of myositis, et cetera, I think lately in my practice, it's the cognitive effects. And what do you think about predictors of who's more likely to get the cognitive effects? And what about dosing with that? I know that if you stop the medications, you can have a reduction or, remission of that. But it's much more common than before. And that's a reason I think that 42% of people stop the medication. That's one of the things.
Lawrence?
I will not tell you my experience because I don't have, but I am a pharmacologist, and one of the dogmas is you have to give the minimum dosage that is effective. So you never use a cannon to kill a mosquito. If you achieve a good level with lower doses, you don't need to go to the skies.
But statins are doing other things like reducing vascular inflammation, endothelial repair, and the studies are consistent time after time again. So, we got to follow what the scientific evidence is. It's not just the LDL cholesterol level.
But then they use Zetia, because Zetia is not a statin. Then you have to stay with the high doses of statin.
I think in Prosper, where they had an older population and every 6 months checked them with these brain testing, there was no difference between the statin and the placebo. And also, I think in terms of reports to the FDA, it's the same as for losartan and clopidogrel, the problems with cognitive functioning. So although you do have people come in and they've lost their whole recital, the piano recital, in fact, you just have to play, you stop the things, and somehow it sort of evens out with time, is my experience. People do complain about it, but I don't think there's too much evidence. In fact, there's some evidence that may reduce the cognitive impairment and if you take a lot of studies together. So I have trouble believing it's in the cognitive impairment problem.
Okay, so Benjamin, we scrutinized the whole issue of cholesterol and guidelines and so forth. What did you learn?
Well, this is certainly a very broad question. I think that I learned that you need to treat different populations differently. That the randomized controlled trials certainly provided evidence that being on a high-dose statin improved outcomes, and that while ezetimibe did reduce LDL and really has important implications for the LDL lowering hypothesis, these patients were not on the standard of care for ACS because they didn't have that data at the time of enrollment of the study. So I think that it would be, I think that Improve It is an important study because it shows that we can affect outcomes, and it's likely via LDL reduction because of the recently published New England Journal of Medicine article that showed that inactivating mutations of the Niemann-Pick-like protein actually, which is probably the mechanism by which ezetimibe work, actually have lower LDL and have lower coronary events. So I think that even though that it supports the hypothesis that it's a very low event rate, and we should be careful not to apply this to a broad population.
Okay, I'd like to summarize what I heard from everybody, and that is the most of you think that we will use a combination of both types of guidelines. Marianne was talking on an individualized approach in primary prevention, which makes a lot of sense. And Dr. Heck pointed out about the importance of calcification, which I tend to agree with that, although it cannot be used as a unique tool. Thank you very much for being here.